in palliative care. As you all know, we are routinely dealing with most of the respiratory symptoms in our routine practice. So, in the palliative care setting, it is little bit different from our normal management of respiratory symptoms. So, we have to in detail, we are discussing the most common symptoms like breathlessness and cough. Okay, this is a post-lunch section, so make it interactive, then it will be interesting. Okay, shall we start? No response.
Anybody please respond?
Okay, shall we start? Chat box. Yes, yes. Okay. Okay, these are the main two topics we are dealing today. That is, one is breathlessness, other is cough. Okay, as you know, in our India, there are so many respiratory symptoms. Patients are having so many respiratory symptoms. Usually, the symptoms are associated with some chronic illness like COPD, interstitial lung disease, some other cancer conditions that will result in respiratory symptoms. So, it is very important to learn how we dealing with the management of the respiratory symptoms in palliative care settings. So, you already studied what is palliative care. What is it is usually the palliative care deals with it is a need based science. So in the earlier we are dealing mostly with the cancer patients or end of life patients. Management is mainly in palliative care. Now it is totally changed. Now it is more addressed or emphasized towards the what the patient sufferings, health, serious patient health related sufferings of the patient along with their family members like caregivers. So it is not based on their diagnosis or the prognosis of the disease. It is we usually deals with the cancer patients and non-cancer patients for the symptom management. So you have to learn more about in palliative care for the good delivering of management for our beloved patients. Okay, the first one is breathlessness. The prevalence of breathlessness in lung cancer is more than 75% because the this is the breathlessness is only a symptom. The underlying disease is different because the patient with COPD, pneumonia, interstitial lung diseases, if the patient has some pneumothorax, emphysema, pulmonary embolism, some advanced cancer. So the primary malignancy is some in other organs apart from the lungs, but the patient has some metastasis to the lung, then the patient may be presented with breathlessness. Some other non-cancerous conditions or some non-pulmonary conditions like cardiac failure, renal diseases, these patients are also presenting with breathlessness. So we have to know how to deal or how to treat such patient symptoms. Next thing is the conditions which are due to cancer. What are the main symptoms or what are the underlying causes of the patients with cancer? In cancer patients, if the primary malignancy is in the lungs, there is some tumor or mass which is obstructing the airway or bronchioles or parenchyma, which will result in breathlessness. So the obstruction of the airway that will result in breathlessness. Some cancerous conditions, the patient develop pleural effusion. The pleural effusion is maybe mild, moderate, or massive. If the patient have massive pleural effusion, the patient have presenting with severe breathlessness. So we have to intervene in that case to relieve the symptom. So the next one is replacement of lung by cancer. That is the large mass or the tumor which will replace the entire parenchyma or the tracheobronchial tree or the alveolus. That also results in breathlessness. Next one is lymphangitis carcinomatosis. That is the tumor which infiltrates into the lymphatics. That will also result in some pleural effusions, or that will again cause what breathlessness. Next is some cancer microemboli, pericardial effusion, cardiac metastasis, the everything, the conditions which related to the lung, parenchyma, trachea, bronchio, alveoli, and the organs which surrounding the lungs like heart, and also some ascites. How the ascites will result in breathlessness? Ascites means the collection of fluid in the abdomen. This will result in the pushing of the diaphragm up, and that will result in the restricted movement of the lungs. That will result in breathlessness. So, if the patient is presenting with ascites and the patient has a symptoms of severe breathlessness, we are doing some ascitic fluid tapping. So then the patient has a relief in the breathlessness. So that is also very important. We have to know what is the mechanism of the breathlessness in patient presenting with ascites. Next one is cachexia. What is cachexia? In cachexia, the patient with severe breathlessness, there is a wasting of the intercostal muscles, accessory muscles. So if we are seeing the patient looks very emaciated. So in that cases also, patient have severe breathlessness due to the respiratory muscle weakness. Next one is superior vena cava obstruction. That is the same mechanism that will result in breathlessness. Next is some treatment modalities. Treatment modalities like chemotherapy, radiation. That is also results in the fibrosis of the lung parenchyma. That also causes breathlessness. So these are the some cardiac causes resulting in the breathing difficulty. That is, the patient has a cardiac failure, angina, arrhythmia, myocardial infarction. These also some non-cancerous conditions like cardiac causes. Next important one is anxiety. Okay, if anybody tell what is the role of anxiety that will result in breathlessness? Anyone can tell? Now we are already discussed some medical causes, that is cardiac, non-cardiac, cancerous causes for breathlessness. How the anxiety resulting in the breathlessness? Hyperventilating. Any other options or any other thoughts relating anxiety? I already discussed that. That is correct. Fear. That is fear. Because if the patient, usually this diseases like COPD, interstitial lung disease, these are the chronic pulmonary diseases. So in these cases, the curative treatment is very limited. We have only curative treatment is very much limited. So we have to control the symptoms. So it is a long process. If the patient develops some COPD or interstitial lung disease in the younger age, these symptoms will continue till their death. So it will cause too much frustrations or psychosocial issues with that patient. So some patient, if somebody have this symptom like breathing difficulty, we know what are the thoughts of that patient during that time. If the patient have some breathing difficulty after the control of the symptom, we just ask the patient what is the thought during that breathlessness. Most of the patient tell, I am just scared. I had a feeling of fear of death. So this will increase the anxiety. This anxiety will again increasing the breathlessness. So there is one of the main cause for the breathlessness is anxiety. In our normal settings, nobody addressed their such an issue, that is anxiety. Nobody addressed because they are only what focusing on the clinical aspects or the physical symptoms. But in the palliative care, we have to address the anxiety of the patient, not only the patient but the caregiver also. Because if our any loved one who is suffering from such a bad breathlessness, we cannot see such a situation. We cannot think or we cannot imagine how they are suffering. So some anxiety or some psychological issues also affected by their caregivers also. So we have to address that both patient and caregivers concern. So it is very important to address their psychosocial issues also. So the breathlessness, it is a subjective experience of breathing discomfort because it is a very distressing symptom for patient, caregiver, and doctor. Why it is for patient? Because the patient is really suffering from what they address means they tell that I have air hunger, I am not able to breathe properly, I need too much effort to take a good breath. This is the distressing symptom for the patient. And for the caregiver, the patient is if our beloved one or our any relatives or friends who is suffering from breathlessness, it is very difficult to see such a situation. So it is also very distracting to the caregivers also, and it is very distracting to the doctor. Why it is for the doctor or nurse? Because it is very critical or very difficult to manage the respiratory symptoms, because it is not a curative one, so we have to control the symptom only. So it is we are facing too much difficulties to manage the respiratory symptom. So because the underlying disease, that is cancer or non-cancerous thing, it is a progressive one, so we cannot completely cure the symptom. If the in the case of pain, we are just giving analgesics. The patient, if the patient have a pain score of 10 by 10, you just giving analgesics, maybe the pain score became 0 by 10. But in the case of breathlessness, it is not happen like that. It just relieving the symptoms, or which just reducing the symptom only. So we have also have difficult to manage such symptoms. So that's why I am telling that it is a distressing symptom for the patient, caregiver, and the doctor. Any queries? Somebody's mic is on.
Please unmute yourself.
Okay. Okay. Then we continue. Okay. These are the real issues facing by the patient with a chronic illness like breathlessness. That is, if the patient has chronic lung disease like COPD or interstitial lung disease, they have some limitations in their daily activities. They are not able to go for washroom. They are not able to go to out. They are not able to do their daily activities. They are not able to attend any functions because of their illness. So the patient became more frustrated. Patient became more anxious. The patient became more depressed because of the limited daily day-to-day activities, and the patient become more dependent to the family because somebody may help for their mobilization or from doing other activities. So they become more dependent to the family, and they have the feeling of loss of their role, because if some patients maybe a father or mother, them having a main role in the family, but because of these symptoms, they have lost their main role in their family, because their activities and other social activities, other social engagement, everything was restricted or decreased due to these symptoms. So the patient has feeling of social isolation. These are very, very important for addressing, because if the patient having these symptoms, if we are giving only just medical management, but patient has no relief, we have to address these issues also. Then only the patient gets some relief. If we are giving only medicines, if maybe because of their illness, maybe sometimes it may work, sometimes it may not work. But we have to address these issues. It will relieve their stress, their anger, their frustrations, their isolation, feeling of isolation. It will help to improve their quality of life. So, in the case of this chronic illness, the need of integrating the palliative care into these specialties, mainly today we are dealing respiratory. So, the integration of palliative care in the pulmonology department or pulmonologist is very, very important to control these non-curable disease symptoms. It is very, very important. So, everybody should know how to address the patient's physical and other psychosocial issues. In the coming slides, we are dealing more about how to ask the symptoms, how to examine them, how to examine the patient, how to assess the other things, how to communicate the patient and caregiver about their illness and their further prognosis of the disease or the management. So it is very important to learn. And because of these psychosocial issues, there is a large psychosocial and emotional burden to the family because of this patient. And the patient with the respiratory conditions undergo a social death than before a physical. That is because of their social isolation, loss of their activities, loss of their role. They become before their physical death, the emotional or the social death is happening because of their restricted activities. And the most of the patient have anxiety. Because of their anxiety is due to the fear of death, because the patient is gasping or the patient is take effort to take a good breath. So there is fear of death is very common in these patients. So usually the patient, if the patient is coming with breathlessness, these are the usual question we are asking, that is, have you breathlessness reduced? If we question like this, the patient says it is yes or no. Your communication class is over? Yes. Communication class is over. Then, what is the type of question is like this, like that? That is, have your breathlessness reduced? Answer is yes or no. What is the type of communication is this? We just, I think already discussed in the communication class. There are some different. Yes, good. Divya, closed question. This is a closed question. In the palliative care, we are for a good communication. The closed questions should be avoided. We are usually we are usually asking about the open-ended questions, because to know more about the breathlessness. That is, if we are asking that, have your breathlessness is reduced? The answer is yes or no. Then the conversation is stopped there. But if we are modifying our question like, what have you given up for avoiding breathlessness? Are you copying it and acknowledging them? Then they are open up their pandora of the issues, that is for breathlessness. Some patients, what are the issues? I am not able to go bathroom. I am not able to do our daily activities. I'm not able to eat proper. I'm not able to attend functions. The real issues they will tell. So communication is very, very important in such a cases. So you have to modify your normal history taking. Usually, patient, how do they describe if the patient is coming, ma'am, I have a breathlessness, or I have dyspnea, not like that. They said, I have a air hunger, or I have an unsatisfied breath, or I have, my breath is don't satisfy me. These are the complaints they are usually they tell to us. And the other thing is the work or effort. That is, some patients tell that it is an effort to breathe. So my breathing requires more work. So these are the normal terms they are using to address their breathlessness. And some said there is some chest tightness. What is chest tightness means? Something wind around my chest. I'm not able to breathe properly. I have to take more effort to take a good breath, because these are the words, or these are the complaints which are telling by the patients. So you have to address their concerns. This is one model called breathing, thinking, and functioning model. Usually, I already tell that there is some cycle, that is some anxiety dyspnea cycle, because in the panic situations or some anxiety will trigger the breathlessness. So if the patient has a breathlessness, there is a fear of death is there. That fear of death will increase the anxiety. There itself again increasing the breathlessness. So there is a cycle like that. Here, if the patient has a breathlessness, so breathlessness, what the patient have using their accessory muscles for breathing, there is short breaths, hyperventilation is there, breathing become more harder, so the patient become very distressed. That time they are thinking that what the patient has too much anxiety. I am going to die. What is my future? Because of these symptoms, I have to, I can cope up with that. What is my future? What are my families? How it deals with? There are so much thinking is in the inside the patient's mind. So it will again increases what anxiety, distress, feeling of panic. This again what it again increases breathlessness. Because of these what symptoms and thinking, the patient have restricted mobility. The patient is not able to move. The patient is because they're thinking that if we are moving, then our breathlessness was increasing. So they are restricting their movements. Most of the patients is not able to lie down properly. Then they are usually we are if the patient has we are seeing the patient is in propped up position. Propped up means semi Fowler's position, because in that position the patient is more comfortable than in the lying down position. So because of the restricted activity, patient have some muscle wasting. So and that will result in cachexia, emaciated patients. So this is a cycle. So breathing, thinking, and functioning. These again increasing the breathlessness. So it is very important to address only the not only the physical symptoms, their psychosocial like anger, frustrations, anxiety, and also their functionings like patient wasting, cachexia. Everything is very important for managing the respiratory symptoms in palliative care. Usually, if a patient, if in a normal hospital, the patient is coming with breathlessness. First, we are taking an history. That is same like that. First, we have to discuss the onset, any palliative factors, and the quality of the breathlessness, any related symptoms with any severity, treatment. Onset means when did it begin? What is the duration of breathlessness? How frequent does it occur? In some patients, there is a twice a month or thrice a month or every week, daily. These are the what is the severity. The next is palliative factors, something what makes it better or worse. In some particular positions will make it better, or in some positions make it worse. These are the palliative or aggravating factors. Next is quality. Quality, how he or she describe their pain. That is, some patients that tell it is very. I already tell that there is air hunger, effort, work. That is that way they are describing their quality of breathlessness. The next thing is related symptoms. Some patients with breathlessness will have cough or other any other symptom, respiratory symptoms, or then abdominal pain, or any anxiety part, any isolation part, and severity that is based on the score, like pain only. Then treatment, that some patients chronic illness they are taking inhalers. That is very important to take the past history about the treatments. So everything is very important, because we have to know the what is the what is the disease condition. It is a progressive one or non-progressive one. So we have to know everything is very important to managing such patients. Next one thing is physical examination. Is everything I think you already know. Because every patient, if the patient is presenting with symptoms, we are now just first we checking in the vitals. That is heart rate, BP, respiratory rate, saturation, pulse oximetry. That is in normal settings, the saturation and pulse oximetry makes a very important role, because if the patient is coming with breathlessness, we are just first the sister will run for the pulse oximetry and check the saturation. The patient has a breathing saturation SpO2 of 75%. Suddenly we start what? If the patient has a SpO2 of 75, suddenly we start what? Nothing started? Oxygen. Okay. Then what next? After oxygen, what next? Only oxygen? Only oxygen. No injection, nothing. Ah, yes, Fowler's position. Good. Okay, propped up, same thing, propped up position. Yes, injection hydrocortisone, IV line. Yes, yes. Yes, yes, good, good. These are the normal patient presenting with the breathlessness in an hospital or in a normal settings. But it is little bit different in our settings as a palliative care physicians. So we will check the saturation initially, but usually in the ICU settings or in other hospitals, we are keep on checking the saturation, and our treatment is mainly depending upon the saturation. We just keep on checking, that is the saturation is falling, it will become 75, it becomes 70, then 65. And our treatment is also like that. We are not focusing mainly to the patient. But in the palliative care, we are mainly focusing to the patient symptom. So we are just checking the saturation, but not keep on checking or giving continuous oxygen. We'll in our coming slide, we'll dealing with the management part. We'll tell more about the management to the oxygen therapy and the pulse oximetry checking everything. So this is the routine checkup, that is saturation. Then look for cyanosis. Cyanosis means it is the bluish discoloration of the lips or the peripheries due to the hypoxia. Next is system examination, include inspection, palpation, percussion. Then inspection part, we are just seeing the patient is using any accessory muscles for breathing. What is the condition of the patient? Is patient is cachexia or emaciated? Any other breathing difficulties or any ascites is there? That everything was looked in the inspection part. Next is a physical science, like the position of the patient. That is mainly very important. Most of the patients in the semi-fowlers or the propped up position, and they are using active accessory muscles. If the patient has a chronic illness, the patient has a severe nasal flaring is there. And the pursed lip breathing, that is the mouth breathing, is also common in COPD patients. These are the physical examination part. Next thing is investigations. What are the investigations we are normally doing in patients presenting with breathlessness? What are the important investigations we are dealing if the patient is presenting with breathlessness? Anybody? Chest X-ray, good. Okay, chest X-ray. Anything else? ABG, very good. PFT, okay, it is not routinely using in an acute exacerbation of breathlessness. ABG and chest X-ray is good, correct. Okay, these are the things we are doing in an normal setting. But in the case of our palliative care, uh, we should be do some investigation. But before doing the investigations, we have to think. It became any benefit, or it can alter the line of management for the patient, or it get any benefit to the patient. Then only we can do any investigations. Most of the patients we are dealing in palliative care is some chronic illness or some progressive disease due to cancer or some non-cancerous conditions. In that patients, there is no point to doing such investigations to alter their quality of life. So we are not routinely using any investigation like X-ray or ABG in a palliative care settings. If the patient needs some correctable things, or the patient can improve their quality of life with that investigation, then we will do. Otherwise, we are not routinely doing any chest X-ray or ABG or continuous SpO2 monitoring, anything. Nothing was done in our palliative care settings. So the investigation, before doing investigation, if it is done, if it is only going to alter the line of management, it is not very useful in assessing chronic breathlessness due to their advanced disease, except to exclude the treatable problems such as pleural effusions. If there is something, some treatable or some correctable problem is there, then we will do. Otherwise, we didn't do any routine investigations like X-ray, CT, or ABG. Before that, the communication, that is very, very important in dealing with the patient with the respiratory symptoms, because I already said that there is some differences in palliative care and normal setting when we dealing with the respiratory symptoms. One thing is the oxygen therapy, the other thing is this investigation part. because if the patient coming with breathlessness, most of the caregivers tell doctor just start oxygen, then the patient have some relief. They will compelling us or they will force to us to start oxygen or some doing some investigations. So the proper communication to the both to the patient and the caregiver is very important, because we have to address what are the conceptions or what are the expectation or insight about the disease of the patient to the caregivers. So we have to explain what is the condition, because the patient has some progressive disease. So it is a non-curable thing. So we have some life. What is the life expectancy of the patient? So if we are doing such investigations or oxygen therapy for this patient, it will not give any benefit to the patient. So it will communicate prior to the patient and caregiver. It is very important. Otherwise, they will beaten us. If the patient had a sudden death or something happened, they will beaten us, because the communication is very important for such a patients. We are dealing with such a respiratory symptom management patients. So we have to address the patient and caregiver. Not only the patient, but the caregiver also. If we are shifting the patient to ICU, if the patient with breathlessness, can we shift the patient to ICU if the patient has breathlessness? Yes. Only yes? Any no's? Anybody have an opinion that no? Yes, one requires ventilator support, okay? If the patient is like, okay, stable with O2, okay. Okay. Everybody says it is they are shifting to ICU, but I says no, because if the patient has a progressive disease, and if there is the what the quality of life, the patient came back to a normal quality of life is very less. So the life expectancy of the patient is also very less due to their progressive illness. So we have to communicate that these are the conditions of the patient. If the patient is shifting to ICU, if the patient has a wish that the patient is separated from the family members during their last minute or during this distress period, most of us that we are happy to or wishes to being with their family members. If we are shifting to ICU, that he or she became alone, and she's in such an unfamiliar surrounding in the ICU with so many deep sounds, so many lightings, with too much AC. So the patient is very much distressed, and that will result in anxiety, and that is again increasing the breathing difficulty. So we just communicate the patient and not only the patient, the caregivers, that this may or may not be beneficial. Most of the time, it is may not be beneficial to the patient. So if the patient has a wish to being with the family members, then it is not to shift the patient to ICU. This is the routine thing we are dealing in palliative care if the patient has a severe breathlessness. If the patient has an acute breathlessness with some reversible or correctable cause with ventilator support or something, then we can advise. Otherwise, in a cancerous condition or some progressive disease like COPD, there is no point or to shift the patient to ICU. There is no benefits in for that shifting. The patient has increasing their distress only. There is no benefit to the patient. So the decision we should be making with the family and the caregiver. After discussing with the family and caregiver, we have to explain what are the what benefits and what are the risk factors for that. Then the decision will made by the family members. But the proper communication is very important. This is the problem. Anybody have any queries? Okay, no. Okay, shall we continue? Okay, next, the proper management of the breathlessness. Usually, we have a thought that there is no active interventions or no treatment in palliative care. Only some what supportive care is there, or some. So, but in some cases, the patient have some correctable things or some treatable cause is there. Then we will identify that and we will correct it. So, if in the case of the breathlessness also, if there's some correctable cause is there and that will improve the patient quality of life, then we will proceed with the correctables. The next one is the non-pharmacological management of the breathlessness, and the other one is pharmacological. Here, the non-pharmacological is very important because it is little bit different from our normal studies. So we have to learn how to deal and non-pharmacological methods to treat such a patients. What are the correctable things? If the patient with COPD or asthma, if they are presenting with some acute exacerbations, we are usually giving some bronchodilators and corticosteroids. Bronchodilators, the bronchoconstriction will result in breathlessness in asthmatic patients. So if we are giving the bronchodilators, it will dilate the bronchioles or alveolus, it will relieve the breathlessness. Now, okay. The next one is steroids. Steroids are usually the tumors or what any infective conditions. There is a peritumoral edema is there, so we have to reduce that edema. That will relieving the airway edema, results in the relief to the patient by giving corticosteroids. Next is if the patient has some respiratory infections like pneumonia or something, just we are giving the antibiotics. Then it will relieve the infection. In that way, the breathlessness may be reduced. Next one is pleural effusion. In pleural effusion, the tapping of the pleural fluid, or in ascites also paracentesis, giving diuretics, that will relieve the symptoms. In some cases, patients presenting with anemia, that also results in breathlessness. In that cases, if we are giving blood transfusion, then their HB become improved, then the breathlessness will decrease. In heart failure patients, we are giving diuretics, AC inhibitors. These are the some correctable causes. So in that cases, we are identify the correctable causes and we just correct it. Then it will result in the symptom management. Next is non-pharmacological thing. In these patients, what usually I already tell that the patient have anxiety is very high in this patient. So just calm presence of healthcare team conveying empathy will relieve the anxiety. So just inform or just hang on the patient and tell that our team members, that is our doctor or nurse, anybody will sit by the side of the patient and make the patient more calm. So that itself will decrease the anxiety and that will decrease some extent in the breathing difficulty. So it is very important make the patient calm, and the empathy is very important to the patient in such a situations. So make the that because of the dyspnea anxiety cycle, the anxiety is very important. So we have to calm the patient with our presence, our address their concerns, our communication. It's everything is very important. Next thing is comfortable positioning. That is, I already tell that it is semi-fowlers or propped up position. This is most patients preferring the propped up position. So make the patient more comfortable. Next is loosening the tight clothes, because the patient, I already tell that patient has some feeling of chest tightness or something wind around their chest. So the tightening clothes will increase the breathlessness. So the loosening of the tight clothes will increase the airway or space for perception, that will thereby decreasing the symptom. Next is one is handheld fan or table fan. This fan will in front of the face, that will improve the circulation in some extent, and some patients have some relief with this handheld fan. Some patients, if the patient has relief in their symptoms, we can continue it. If some patients it's not working, then it can discontinue it. And some open doors and windows, that will improve the circulation by increasing the perception of space. So these are the main non-pharmacological things. This is not a first line or main management of the symptom, but it has some supportive role in the management of the respiratory symptoms. So it is also very important. Next, we are dealing with the pharmacological things. That is, we just know that what are the how we correct the correctable things. what are the non-pharmacological things. Next, we are dealing with pharmacological management. In the pharmacological management, first we can give some bronchodilators, short-acting bronchodilators or long-acting bronchodilators with or without O2. And next one is steroid. It is very important. The steroids, they are reducing the peritumor edema and airway edema. I already tell that if the patient has a mass or tumor in the lungs, there is some edema around their tumor. That will increase the edema of the airways. So it will restrict the movement of the air circulation. So if we are giving dexamethasone or steroids, it will reduce the peritumor edema and the airway edema. It will release the diameter of the alveolus. That will result in a great relief of the symptom management. So the steroid is very important for an acute relief. Next one is nebulizations and antibiotics. If patient has any evidence of or signs of infection, we can give antibiotics and some nebulizations, some bronchodilator as Stalin or Duolin, Budicort nebulizations can cause some bronchodilator effect is there. That is also helping the relieving of symptoms. Next one is morphine. I think you are thinking that how the morphine effective for breathlessness. We have already studied that it is a strong opioid. It is mainly using for the pain because of their strong opioid nature. In the coming slides, we are dealing how the morphine acting for the relieving the breathlessness. And the other thing is oxygen therapy, NIV, and anxiolytis. That is we are dealing in the coming slides. That is morphine. First one is morphine. Usually, the morphine, we are dealing with the morphine usually for pain management or in an analgesic effect. But in the low doses of opioids like morphine, it is a very safe and effective for breathlessness management. But it is normally for if suddenly a young patient coming with breathlessness, if we are giving morphine, no. It is usually for the intractable dyspnea. That is, if the patient is not responding to any treatment, normal treatment like any autotherapy or any antibiotics, any other management of respiratory or steroids or nebulizations, any normal treatment of the breathlessness, the patient is not responding. That is known as intractable dyspneas. In that cases, we are considering low dose morphine. It is very safe and effective. And what is the mechanism of action means? The morphine will act on the respiratory center by reducing the respiratory rate, and it is also reducing the sensation of breathlessness. So this will decrease the respiratory drive of the patient. Thereby, the patient has a symptom relief. So it is very, very important to know how the morphine acts to relieving the dyspnea. So it acts on the respiratory center and reducing the respiratory rate, and it also reduces the sensation of breathlessness, and thereby it is decreasing the excessive respiratory drive. We completely relieving the not only the completely relieving the breathlessness, it will decrease the respiratory drive. So we have to communicate the patient that it will help you to decrease your respiratory drive or hyperventilation. So it also reduces the anxiety. Some action for the anxiety part also. So it will again reducing the work of breathing and reducing the anxiety. The dose using for the management of the dyspnea is usually very low dose when compared with the analgesic dose. Usually we are starting as a 2.5 mg TDS. We can titrate with the response of the symptom management. We can given as an 8th hourly or 6th hourly up to 5 mg. For the pain management, we are usually starting as a 5 mg Q4 or Q6 hourly. But in the respiratory management, we are starting as a very low dose, that is like 2.5 mg TDS. And the sustainable release tablet also available to relieve the symptoms. Next one is oxygen. Is it really helpful? The oxygen is, if we are giving oxygen, what is your opinion about that? It really helpful? Anybody? Not fully. Okay. Yes. Veronica says yes. Any other opinion? Can be toxic. Okay. Yes. Sonam S. Okay. Okay. Somebody has S, somebody has no, some is partially, fully. Okay. So we have to know what is the underlying disease condition which causing breathlessness. If the patient has a progressive disease or a tumor which causing an obstruction to the airways, so does it helpful if we are giving O2 oxygen? If patient has an airway obstruction, but we are continuously giving oxygen, there is no point in giving such oxygen. It will not do not what do not what resolve or control the breathlessness because the cause is different, and we are giving some another thing. If the patient has some hypoxic episodes, then if we are giving oxygen, then it will improve their saturation. So usually we are doing like that, means we are giving oxygen trial. If the patient coming with breathlessness, we can give a trial of oxygen for a 10 minutes. Because if the patient has some improvement after giving oxygen, then we will continue it. Otherwise, if the patient we are giving, if the patient has a saturation of 75, then we are starting oxygen. The oxygen saturation became 85, but patient has a persistent breathlessness. Then there is no point in giving oxygen. Maybe if the increased oxygen will cause to retention and the patient become more drowsy and toxic effects may happen. So usually we are giving a trial of oxygen for 10 minutes because the oxygen blood equilibrium is takes 7 minutes. So if we are giving for 7 to 10 minutes, if the patient has an improvement with that, then we will continue. Otherwise, if the patient has no improvement with the oxygen, then we will stop. So proper communication and documentation for that is very important. That we have to address the patient's perception that these are the condition of the patient because of their underlying condition or progressive disease. The patient is not coping with the oxygen. No, it is not beneficial to the patient. It may cause harm. So that will try to explain to the caregiver and try to understand it, then we have to withdraw the oxygen. Otherwise, they will beat us or they will blame us why they are not giving, the patient has a breathlessness, they are not giving oxygen. So it is very, very important for proper communication and documentation before giving oxygen, and communicate the patient that we are giving only for 10 minutes. If the patient has improvement, then we will continue. Otherwise, we will stop. The way of giving oxygen also, usually we are giving in nasal cannula and face mask. The most preferable one is nasal cannula because while we using the face mask, the patient has a feeling of because of their breathing difficulty, patient has a really in distress and suffocation. In order to that, if we giving face mask, there is a increasing the sense of suffocation, and because of the oxygen is a dry gas, so it will give dry up to the airway. That will also again increasing the distress to the patient, and there is difficulty in communication with this mask. So this also increasing the distress to the patient, and again we are increasing the patient's anxiety and also patient's anger, frustration, depression. Again, they will we will increase. So we have to consider the as a patient, what is the patient symptoms, address their concerns, address their issues, and try to handhold them with that, and try to understand their issues, then try to solve that issues. That is very important. Next, we are just giving morphine, and we are just give some non-pharmacological things. Next one is benzodiazepines. Usually, we are giving benzodiazepines to relieve their anxiety part. So this is are not a first-line agents. Is we are giving benzodiazepines as a supportive treatment to relieve the anxiety. Most commonly, we are using a short-acting midazolam. We can also use long-acting lorazepam also, but it is only a supportive. This is keep in mind that it is not a first line management, it is a supportive management along with morphine or any other treatable causes. It will relieve the anxiety. Next is terminal breathlessness. It is very difficult to manage that terminal breathlessness. Maybe it is may not responding to oxygen or morphine. So in that cases, we are giving morphine as a continuous infusion. And in this case also, proper communication is very important. We have to tell the caregivers that the patient is in the terminal stage. So we have some difficulties to manage their breathlessness with the normal treatment. So we have to give some benzodiazepines like midazolam. The patient is not responding to this morphine or benzodiazepines, we will consider palliative sedation. I think you have classes with palliative sedation later. In that we will in detail where you are discussing what is the sedatives we are using for palliative sedation. So this is mainly for the terminal breathlessness. Okay. In that case, we are just finished the breathlessness part. So mainly, yeah, the breathlessness cases, we are focused on the quality of life of the patient. That is very important. So just only, symptomatic, or not only the symptomatic management, we are just focusing on the quality of life of the patient, also addressing their psychosocial issues. So integration of the palliative care from the beginning is very important. If the patient diagnosed with a COPD or interstitial lung disease or some chronic lung diseases, we have to integrate the palliative care initial itself. In that cases, we can communicate the patient or caregiver about what is the future, what is the progression of their disease, or how it will affect their life expectancy, quality of their life. So the patient and the caregiver is aware and they are ready to accept that. The patient has most of the pulmonologists or other specialists, they are referring the patient usually at the end of their disease progression or the end of end stage. In that time, the communication is very difficult because the acceptance of the patient and caregiver is very difficult, and we have facing so many difficulties to manage such patients. So the integration of palliative care at the beginning is very important in such cases. Then they will understand, these are the things we are coming face. So we can do such things for the breathlessness if the patient has severe. That is very important. Communication, if their integration is started from the beginning, and the need to slowly sensitize about the prognosis. That is mainly we can get after a proper communication. The aggressive management, we can avoid an aggressive management at the end of the what disease progression, because there is no point or there is no benefit to the patient by the ICU admissions or intubation, ventilator, tracheostomy. There is no point or no benefit to the patient during the end stage of the diseases. So we have to communicate earlier to the caregiver and patient, then they will prepare. Okay, this will happen, but there is nothing, no benefit or no what good. There is no improvement in the quality of life after admitting in ICU or any intubation or ventilator. It may cause more distress to the patient. So they will aware, and there is better version of yourself and their ethical and stress-free period during the last stages of their patient life. The patient and caregivers may be calm and they will accept it. Then the last period is may become more smooth for the patient and for caregiver and also for our healthcare professionals also. Next thing is cough. Here, the next most common symptom which we are dealing commonly due to the chronic illness. The tumors are more likely to cause cough with involvement of airways than lung parenchyma. That is, the tumor which involved in the airways, which involved in the airway or bronchi, they will result in the cough. Then lung parenchyma. The cancer involvement of the pleura, pericardium, mediastinum, pulmonary lymphatics, and blood vessels may cause cough. These are the causes for chronic cough. Next one is aspiration. Usually, that bedbound patients or some chronic illness patients, they are more prone for aspiration pneumonia because the patient has the most of the caregivers, they are feeding in an prone supine position or lie down position. During that time, because of their inappropriate reflexes or muscle weakness, there is a chance of aspiration is there. So that will result in aspiration pneumonia or aspiration pneumonitis. These also result in cough. And the conditions with hypersecretion of mucus, that is also associated with the cough. The patients came with chronic cough. They can result some physical complications like chest wall pain, fracture of the ribs, urinary incontinence, sweating, exhaustion, disturbances of sleep. Because some patients have a cough more during the night time, so the patient has a disturbed sleep. The disturbed sleep again causes some psychosocial problems like anger, frustration, depression. So many issues can cause. These are the physical complications. This will also result in some psychosocial issues also. So we have to address that also. Next, some treatment modalities for cancer. Usually, the treatment modalities for cancer is chemotherapy, radiotherapy, steroids. So these radiotherapy and chemotherapy may also palliate some cough due to tumors. Some steroids. I already told the mechanism of action of steroids in cases of tumors. That is, it will reduce the edema and decrease the airway obstruction. That will again relieving the cough and identify the correctable. If so any infection or any other effusion or something, some correctable cause is there, we have to identify that and we will correct that. That will again relieve the cough. And some symptomatic management like giving centrally acting antitacids like morphine, hydrocodone, codeine, dextromethorphan. They are the antitacids which are helps to relieve the cough. Morphine usually in low dose morphine is rarely we are using. Most commonly we are using morphine breathlessness. So it has some extent of relieving symptom for cough also. These are the things we are just dealing. It is little bit boring and it is a little bit difficulty to understand what is the management part because it is different from normal settings. But we have to in the finally we have to address identify the symptoms and identify what is the reason for these symptoms and address the patient's concerns and caregivers' concerns and integrate the palliative care to the all of our patients and give a better care or delivering better care to our beloved patients. That is all. And thank you so much. Any queries?
Please ask your doubts. Nobody has any doubts? Can we move on to the case presentation? Madhavi Bandodkar will be ready with the case. Madhavi, please unmute yourself and I will share your case. Excuse me, wait for a minute. There is a technical glitch. Madhavi, now you can start the session.
Yes, ma'am. Good afternoon, everyone. My name is Madhvi. My patient age is 68 years old, male. The diagnosis of the patient is COPD with the hypertension. Presenting complaints of the patient was cough from the past 3 days, fever for the 3 days, breathlessness from past 2 days, and weakness from past 3 days. History of illness. Patient is a known case of COPD for past 8 years and hypertension for last 10 years. Now patient has come to OPD with chief complaints of cough since 3 days, fever since 3 days, breathlessness since 2 days, and weakness. Patient has not received his regular medicine for past 2 days. Vital signs. Temperature of the patient is 99.3 degree Fahrenheit. Pulse rate is 98 beats per minute. Respiration rate 24 breaths per minute. Patient's BP is 130 by 90. SpO2 of the patient is 94%. Respiratory system. Inspection symmetrical in shape and size. Auscultation, wheezing sound was present. Percussion, hyper resonance was there. Blood investigation, CBC was given to the patient, then the chest X-ray and the chest physiotherapy to learn the breathing exercises. Psychosocial aspect, 68-year-old married man living with his 62-year-old wife and 32-year-old son. Patient has retired as a peon 8 years back and his son works in a private sector. Now the main source of income is from his pension and son's monthly income of 10,000. The medication given to the patient was tab paracetamol 500 mg SOS, tab ethofilin and theophylline BD, tab telmisartan 40 mg OD, tab B-complex OD, syrup loratadine, ambroxol hydrochloride, guafenazine TDS, and diolin nebulization TDS. Main concern for the patient is improving breathing pattern, medication compliance, proper treatment and follow-up. Summary, 68-year-old male has come to OPD with chief complaints of cough, fever, breathlessness and weakness. Patient is a known case of COPD and hypertension. Patient requires symptom management, psychological support and coordination of care. Discussion point. What are the main goals of COPD management? What strategies to be used to manage breathlessness and other symptoms? Thank you.
Okay, good presentation, Madhavi.
Thank you, ma'am.
Okay. The patient has a non-case of COPD since 8 years, and poor drug compliance is there. Am I right?
Yes, ma'am.
Okay. Patient is staying with her wife and son.
Yes, ma'am.
Okay. Now the patient has the symptoms of fever, cough, breathlessness, and weakness since 3 to 4 days. Maybe an exacerbation of COPD symptoms because of their poor drug compliance. Okay. We already discussed how we are dealing with the COPD patients and the breathlessness. So anybody can tell what is the main goal of COPD management? It is a curative management or symptom control management. Symptom control, good. Yes, because it is a progressive disease. We cannot cure COPD. We can only control the symptoms of the COPD. So we can control the symptoms with medications, and I already tell that we have to address their concerns, main concerns and insight of the disease. from their caregivers, because what they know about COPD, what is the main issues, main psychosocial issues. It is not mentioned, I think, here. If we are talk with the patient in detail, we can assess that also. Because of their symptoms, why the patient has not taking medicine, we have to explore that. Some psychosocial issues may be there, some anger or frustration, some some limited activities, isolation, feeling of isolation, loss of their role in their family. Something is there. Some reasons behind there to why they are not taking medicines regularly. So we have to address that. We have to find that. Sit with the patient and talk with the patient and try to understand what is the reasons, any other psychosocial anxiety part is there or not. So we have to identify that. And another thing is that if the patient, the examination part, the patient saturation is 94. Is it okay for COPD patient? The saturation with a 94, SpO2 of 94 in COPD patient is okay or not? No. Any other answers? Everybody says no? Okay. No. No. Yes. So many answers. Okay. If the patient has some chronic, what is COPD? What is the full form of COPD?
Chronic obstructive pulmonary disease.
Yes, very good. It is an obstructive pulmonary disease. So we have to maintain the oxygen level between above 89. The 94 is okay. In the patients, usually we are telling that if the patient has maintained the SpO2 of 89 and above is okay in patient with the COPD. This is not in the case of a normal. If patient having a COPD, the SpO2 of 89 and above is okay. So if the patient with 89 with severe respiratory distress, then we have to intervene that. Otherwise, the 89 saturation is it is okay. That's why I'm already tell that we are not only focusing the SpO2 or pulse oximetry. We have to focus mainly patient symptoms. The patient with 89 saturation without breathlessness, it is okay. But patient have 89 with the distress, we have to intervene that. That is the main thing. Another thing, the patient have a sudden onset of breathlessness, fever, cough. We have to identify any underlying infection. So if some infection is there, we have to. It is a correctable thing. So we have to. We will give antibiotics after. I think blood investigations was done with CBC. So if some evidence of infection is there, we can give antibiotics. And if any anxiety part is there, we can give a small dose of benzodiazepines to relieve anxiety. So next discussion point is what strategies to be used to manage breathlessness and other symptoms. These are the strategies I already mentioned. That is the symptom management along with the proper communication and also the address the psychosocial issues. These are the main things. What? Yes.
Madhavi, are you trying to tell anything to us?
Okay. 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 Already, we have discussed that what are the strategies to dealing with the breathlessness and other symptoms like cough, because strategies means correct any have any correctable things when we correct it, and some non-pharmacological things that is for the acute exacerbation or acute breathlessness, and some other medical or pharmacological management to treat the symptom control and to address the psychosocial issues and try to understand their issues and try to solve it. And what next is the proper communication. These are the main strategies to manage breathlessness. Any other questions or queries about this patient story? Anybody have?
Please feel free to discuss.
Madhavi, you have any doubts or any queries?
No, ma'am.
No. Okay. What is saturation to be maintained? That's I already tell that COPD patients above 89 is okay if the patient is stable or without any breathlessness. 89. Usually we are telling that above 89, not 95 or 96, because it is a progressive lung disease. Above 89 is okay. Usually we are giving out of at 2 liters. We are in nasal cannula. We are giving 2 liters. 2 to 4 liters we can start. We are giving for it 10 minutes because the blood oxygen equilibrium will attain within 7 minutes. So if any improvement with O2, we can get it in within 10 minutes. So we will give a trial of 10 minutes O2 with the 2 to 4 liters via nasal cannula, most preferably a nasal cannula. If the patient has an improvement, we can continue. Otherwise, we just stop it. Okay, thank you. I have exams for that after.
Yes, ma'am. Already 2 exams I have attended.
Okay. Okay, this part is very important for your exam point of view also, because the non-pharmacology, if the you may have questions like the patient presenting with breathlessness with underlying this much severe disease, and how will you manage? So in that case, we have to write all of our management part, that is correctable non-pharmacological methods, pharmacological methods, and address their psychosocial issues like anger, frustrations, anxiety. Everything was very important. So you have to study very well, and you have to study it very well. Then we can practice in our palliative care settings with little difficulties. Okay.
Okay, we have time. If you have any doubts related with the session or with the case presentation, you have time. Feel free to ask. If there is nothing, we will end the session. Does anyone have doubts? Okay, then we are winding up the session. Firstly, I thank our beloved Pallium India's Dr. Susan John for the wonderful session. She has described everything, and I also extend my sincere thanks to Madhavi Bandodkar, who had presented a wonderful case presentation regarding this regarding our topic. And I expect more attendance from the next session onwards. Okay, next week we will see again. Till then, I wish you all the best and have a wonderful learning experience with IECO, because we are uploading all the learning materials in IECO, but our assignments are getting not as much as response we expected. So please attend our assignments very promptly, because otherwise it will, you are burdening yourself with by keeping many things pending. So don't keep like that. Okay, please progress with your assignments. We are ending our session today.